Okay, let's begin. Welcome again to Bioelectromagnetics. Today's lecture will be on the interaction of radiation with biological organisms, focusing on non-ionizing radiation. So this week we'll be talking, as I mentioned, about non-ionizing radiation. We talked about the interaction of radiation with biological organisms in more general terms last time, and we'll be focusing on non-ionizing radiation applications. So for example, transcranial magnetic stimulation, tumor treating fields, transcutaneous electrical nerve stimulation, electroporation-based transfer of drugs. I want to also bring your attention to this final lecture, special topics. Now, we've been doing short assignments, and I've been receiving those, and I appreciate that. And the main final project will be to find a paper in bioelectromagnetics in the scientific literature, an original article, not a review article, but an article, research article, and write a summary and critique of that paper. And so by next week, you should be collecting and share with me via email your preliminary sort of selection of such a paper. I will send a notice to everybody about this, but I wanted to mention that in the lecture. And then be prepared, probably online using a Zoom conference, but be prepared to talk for about 5 minutes, 5 to 7 minutes, give an oral presentation of your summary and critique of the paper. So we'll see how it goes in terms of the timing. So that is the final project. Most of your grade is based on the attendance, participation, and the short projects. But we will have that final project, which will be about 30% of the grade. And as you know, this is a pass-fail class. So let me know if you have any questions, but you notice here the final session will be discussion of papers that you need to select in the next couple of weeks. So if you can select a paper by next week, that will be very helpful. And because I want you to focus on searching for the paper, it could be in any area related to the interaction of electromagnetism with biology. I will give you a question for the short assignment, but you don't have to send it in this week. Focus instead on selecting your paper. Okay, so the question for today, which many of you have answered, is give an example of using non-ionizing radiation in medical diagnosis or therapy. And we're going to give some of those examples in today's lecture. So just by way of review, we talked about thermal effects and hyperthermia in the last lecture. We talked about radiofrequency methods. We talked about electromagnetic fields and the health effects and behavioral effects and some aspects of mobile phones. We made a very important distinction between ionizing versus non-ionizing radiation. We talked a little bit about light from the sun as a black body and near infrared light in the lower region here. And that's related to heat. We talked about thermal effects and hyperthermia. Basically, hyperthermia or high temperature, increasing the metabolic rate and indirectly creating oxygen radicals that can then damage proteins. And those protein damages can be nuclear proteins, inhibition of cell proliferation, and membrane proteins and membrane damage, ultimately leading to tumor death. There are two types of tumor death. There is apoptosis due to low dose heat, namely programmed cell death, that the cells go into a track in which they will ultimately die, or high dose heat, physical damage, which is necrosis. So we've used hyperthermia therapy, HT, for cancer to kill cancer cells. So the idea is that heat-induced vasodilation increases the oxygen supply, and tumor cells are particularly susceptible because of leaky vasculature to these oxygen radicals. Of course, there are some practical limitations. The tumor can be very deep. Heating can be non-homogeneous. It can be not uniform in the target area. There can be side effects, of course, of burning, blistering, pain, and collateral damage to normal tissue. Other approaches, which are a little bit more focused, are magnetic hyperthermia, and as we'll see, also radiofrequency ablation, where radio waves are not dangerous, but if you do it with enough intensity through a needle in a localized area, that radiofrequency ablation will move ions, and that movement of ions, just like movement of electrons in electric circuits, ultimately bounces around, creates thermal heat, and that heat, radiofrequency heat we call it, will kill tumor cells, again by the mechanisms that we talked about. In very low, extremely low frequencies, we have AC power, CRT monitors, AM, FM radios, TVs, cell phones. These are in the non-ionizing area, and we've seen some biological effects. We call them major dispersions or interactions with biological tissues. And the very low frequency of the alpha type, counter ion effects, basically moving those ions that we described like in the radiofrequency ablation. Obviously the intensities are less, so we're not heating up. But that being said, various ions that are involved in the cell structure, such as the ions that are around the membranes, can be moved, and there could be potential effects that way. Not so much heating effects, but what we call counter ion effects. The beta type dispersions are at slightly higher frequencies. We see some protein molecule response, and then the higher frequencies, gamma, that approach the sub-terahertz region are dipolar mechanisms in polar media, such as water, salts, and proteins. So we talked a little bit at the last lecture about electromagnetic health effects. At the low frequency, which would be low induced currents, no proven effect of environmental effects. The high induced currents with high frequency radio waves and microwaves do have heating effects, but those are non-specific. It's just heating as we described. And then when you get to the infrared and ultraviolet and visible spectrums, we start to see photochemical effects, electronic excitation. And in next week's lecture, we'll talk, of course, about ionizing radiation, which has very well-established health effects. So what are some of the biological effects? Split DNA molecules, alignment of E. coli and bacteria, non-spherical particles, such as E. coli being rotated in these magnetic fields, movement of particles, shape of cells being changed, some cell death from potential membrane damage, and cell fusion. So some of these might be, essentially totally benign. When we have our skin and we squeeze our arm here, we're not, injuring. There is, of course, a certain plasticity of cell shape. So movement of that cell shape, movement of ions may be entirely within normal parameters, but nevertheless, it is clear that there are biological effects. Whether those are dangerous or not is still an open question. And of course, related to intensity. So some effects, controversial, that we've described. This becomes even more of an issue with 5G, with higher frequencies, more of those gamma effects, as we said, the dipolar effects. And so this is an open issue. So today's lecture is about the interaction of radiation with biological organisms. We'll focus on non-ionizing radiation. We'll focus on specific applications that we do currently in medicine. So even though this is a frontier convergence field with a lot of future possibilities, many of the applications are actually being done now, FDA approved, current practice, and so forth. So I want to go over most of these aspects, the established applications, so that we understand that even though there's a lot of futuristic possibilities, and that's why I want you to read those papers as the assignment, so you start to see what are some of the future applications. As students, you may be inspired to go and develop the next applications of bioelectromagnetic medicine, especially in this COVID situation where we don't have treatments, or treatments are not definitive, and drug treatments are not possible. So we need to have new ways and new approaches to these sorts of problems. Of course, cancer and other conditions, we have drugs, we have treatments, but of course they're not always 100% curable, always 100% effective. So there's always room for improvement. So there's a lot of future in bioelectromagnetics. In today's lecture, I want to talk about some of the present applications so that we understand the current context. So one of those present applications is what's called Electroconvulsive Therapy, ECT, which is used to deliver electromagnetic waves in the context of psychiatric disorders. And we'll talk about that. Another related approach is transcranial magnetic stimulation, using magnetic waves, magnetic fields alternating to create electromagnetic changes at the target tissue. Tumor treating fields, TTF. Another very common application is transcutaneous electrical nerve stimulation, also abbreviated TENS. And the last application we'll talk about is electroporation-based transfer of drugs. So drugs getting into the body, we use electrical fields to enhance those drugs to get further into cells or into tissues and so forth. We call that electrochemotherapy. So let's look at this more broadly. So psychiatric disorders, mental health disorders, are very complicated. And there are a number of methods to treat psychiatric disorders. Most of you are familiar with talk therapy, where Sigmund Freud, and of course, was a founder of that. And we've had many advances since then, where you have a therapist and a patient, and they're talking, and that talk therapy can be beneficial to depression, anxiety disorders, and so forth. So talk therapy is one approach to psychiatric disorders. Of course, another approach to psychiatric disorders is psychopharmacology or medicines. So there are antidepressants, antipsychotics, anxiolytics for anxiety, and so forth. So there's pharmaceutical therapy. A third approach, which is more controversial, but it has been in some cases, is surgical approaches for mental health disorders. Of course, there is quite a lot of controversy to that, because surgery, it can be quite permanent, and that can be a big issue with these sorts of situations. If you look at Parkinson's disease, for example, which is a brain disease, and it has mental health aspects, but it also is a tremor, so there's the physical aspect to it. There are well-established surgical approaches to Parkinson's disease, where a needle is inserted into the brain and certain cells are destroyed that restore the overall circuitry that is closer to the normal situation with people without those tremors, without those symptoms. So that we call that functional neurosurgery. So we talked about talk therapy, we talked about pharmaceutical therapy for psychiatric disorders, and we talked about surgery. Another approach to psychiatric disorder, a fourth approach, if you will, to the treatment of psychiatric disorders, is neuromodulation, is some form of electromagnetic therapy, whether it's through space or inserted through needle. And here's some examples of that. There's deep brain stimulation, invasive functional neurosurgery. We talked about that with Parkinson's disease. So this is neuromodulation, but it's also using a surgical approach. So you can characterize it as being both areas, surgery and neuromodulation. There have been also deep brain stimulation for depression, dystonia, which is a form of movement disorder, and obsessive compulsive disorder. Then, in the non-surgical, if you will, non-instrumentative, is magnetic seizure therapy, an intense high-frequency magnetic pulse sufficient to induce a seizure, and that's the transcranial magnetic stimulation that we're going to talk about for depression. That's on the magnetic side. There's also transcranial direct current stimulation, sustained low intensity, constant direct current flow, usually passing from anode to cathode, electrodes placed around the scalp. So that's also been used for depressed mood, anxiety, and other psychiatric symptoms. And then there's transcranial magnetic stimulation. Intense high or low frequency magnetic pulses produce neuronal excitation or inhibition for a variety of clinical applications: depression, migraine, OCD, obsessive compulsive disorder, PTSD, post-traumatic stress disorder, schizophrenia, substance use disorders, and tinnitus, which is a ringing in the ears. Another surgical type procedure, but using neuromodulation, is vagus nerve stimulation. The vagus nerve is coming from the head. It's a cranial nerve that tends to relax the body. It's what we call part of the parasympathetic nervous system. And stimulating that nerve has various effects. So intermittent mild electrical pulses delivered to the left vagus nerve that goes down the chest, and also going back up into the brain. This has had some effect on depression and epilepsy. So those are some of the overview of neuromodulation for psychiatric disorders. So let's talk about depression. So depression psychiatric disorders in general are not so easy to scientifically characterize. With many other conditions, you may have a biopsy, you look in the microscope, you see the cancer. You may have a blood test for COVID-19, you do a PCR test, a polymerase chain reaction, you see the virus RNA. And we have various laboratory diagnoses that can verify certain disease. With psychiatric disorders, these are essentially what we call clinical diagnoses that are based on essentially symptoms rather than specific hard quantitative value, whether it be an image, a micrograph from a microscope, or blood value, or another sort of laboratory test. So there is a book called the Diagnostic Statistical Manual, and it's one way of having various criteria for these psychiatric disorders, and this is one example. It's major depression. So what is the diagnosis of major depression? It's a depressed mood and or loss of interest or pleasure pervasive for 2 weeks is a requirement. And then based on this, some other symptoms, either physical or psychological. So the physical are sleep disorder, appetite, weight change, fatigue, psychomotor retardation, going very slowly, or the opposite is very fast, and psychological thoughts. So if you have this, and then 4 of the following, or 3 with both of these major symptoms, then you get a diagnosis of major depression. And again, pervasive for 2 weeks. So here's a famous movie. It's a Wonderful Life. It's an American movie, and it's a very powerful depiction of depression. So we talked about deep brain stimulation. Deep brain stimulation is not quite totally electromagnetic. It's also surgical. you have an electrode that goes to a very specific region of the brain. So this is guided through a frame. We call that a stereotactic frame that's registered with MRI images or CT images. And that can be done either singly or as a ongoing device, which is inserted and then connected to a battery and pulse generator down in the chest. And so this is an example of those images and the regions of the brain, and they're different, the thalamus, the basal ganglia, and so forth, different regions for different conditions. So in treatment-resistant depression, when we say treatment-resistant, we say essentially talk therapy and drug therapy, first-line drug therapy that don't cure the depression. We call that treatment-resistant depression. So we need to either enhance the pharmacotherapy, enhance the drugs, or progress to what's called electroconvulsive therapy. In terms of pharmacotherapy, we might change the drugs, we might increase the doses, and so on and so forth. But if we move to electroconvulsive therapy, that involves either direct currents, which we'll talk about, or transcranial magnetic stimulation, TMS, which is, there's still some questions about that, the efficacy, the vagal nerve stimulation we talked about, and of course, altered psychotherapy. So we're going to focus on electroconvulsive therapy and electromagnetic stimulation. So what is electroconvulsive therapy? Now remember we talked a while back earlier in the course about seizures and epilepsy, and seizures were a uncontrolled or a widespread electrical activity of the brain. Electroconvulsive therapy, in essence, induces a mild seizure in the brain, and it's been observed that this mild seizure disrupts severe depression for some people, especially older people. It may involve some neural rewiring, might boost neurogenesis, new brain cells. So that's done with some basic monitoring. Patient is typically put to sleep, so there's monitoring for that. There's a pulse oximeter, blood pressure measurements, EMG to record electrical activity from the muscles, which are going to be responding to the seizure, so we can monitor all of these effects. And essentially, the key element is to put stimulating electrodes, as well as, of course, an EEG, which we talked about, and to deliver a direct current. Now, going back to the laws of electromagnetism, you might remember Faraday's law of induction, in which a magnetic flux moving through a circuit, in that magnetic flux or that magnetic field, changing will induce a current field or electromotive force. And that Faraday's law of induction is basically here. You see the electromotive force is minus. In other words, it's in the opposite direction to oppose the magnetic flux. So we get what's called an induced electromagnetic field. Now, why is this important? Because in the previous electroconvulsive therapy, we have stimulating electrodes, and we put a direct electrical current into the area. That produces those kind of alpha dispersion changes we saw, the counter ion flows. Those counter ion flows across membranes shift the membrane potential, so we go above the threshold, we get into the action potential that we talked about in the first part of the course. And that action potential will create this mild seizure. So we have to actually put in electrical current that way. We can also create electrical current by changing magnetic field. And that can be potentially safer and more focused. So we have, instead of putting the direct current, we have a changing magnetic field over the head, and that induces electrical currents in the region that we're interested in. And so essentially the principle is the same, just using a different type of law. So here's a visual representation. If we have a magnetic field, we have a coil, and we move that, and we move the coil this way, then we'll get a certain current in one direction. If we move the coil the other way, we'll get the current going in another direction. So basically moving a magnetic field. So transcranial magnetic stimulation is essentially this Faraday principle. You have a magnetic coil that's creating a magnetic field. You have an induced current in the brain. We have ions, as we mentioned there. So a rapidly changing magnetic field induces a current in the underlying cortex. This is entirely non-invasive. And you can also focus it on individual areas. So you can create a micro seizure in this area, for example, and without doing a direct current. So that's the principle of transcranial magnetic stimulation. So we can do different types of transcranial magnetic stimulation at a high frequency or at a low frequency. So if we do at a very high frequency, the transcranial magnetic stimulation can increase excitability and improve the function of surviving cortex around damaged areas of the brain, for example, from a stroke or a cancer. If we use low frequency transcranial magnetic stimulation, it can decrease excitability, so actually suppressing some electrical activity in the brain. So we can modulate the position, we can modulate the frequency, and of course the intensity for different effects. So magnetic seizure therapy is essentially like this transcranial magnetic stimulation, but higher intensity. So it's more like ECT as we described. So magnet-induced stimulus, relatively high frequency. You target antidepressant regions, fewer side effects, 3 sessions per week, the same effect essentially as ECT. And you also need to have anesthesia. You induce this tonic-clonic seizure, and you need to do all that monitoring, like the EEG, the vital signs, the pulse oximeter, the EKG, and the EEG, and so forth. So, but it's fewer side effects and potentially a better benefit to risk ratio. So that's a little bit about psychiatric disorders and some overview of some non-ionizing approaches to treating psychiatric disorders, from ECT to TMS, as well as some surgically delivered treatments. So now let's switch a little bit to cancer. What is cancer? Cancer is an uncontrolled growth of cells. Normally cells, of course, they grow and they divide, especially in children, and in certain tissues of the bodies, such as the intestines, the skin, and the bone marrow. But in general, this growth is controlled. And at some point, the cells will stop growing. They will die and be replaced by newly growing cells and so forth. In cancer, this growth is not controlled. And there are several ways that, or features or hallmarks of cancer. So for example, a major one is self-sufficiency in growth signals. What does that mean? That means that the cancer cell doesn't need a signal to go into a growing mode. It grows on its own without any of that external stimulation. Then there are also signals, as I mentioned, to control the growth. And so cancer cells could be insensitive to those anti-growth signals. We mentioned that many cells are growing in the body, including in the adult, not just the children, but they will eventually die and then be replaced by other cells that are growing. We see that all the time in the skin. The surface of the skin are dead cells, and there are new cells coming constantly. And so those cells are growing very rapidly, but they have a schedule or program to die over a certain time, and that's called apoptosis, programmed cell death, and avoiding that is one way of developing cancer. Other aspects of cancer are related to the invasion of that, the cancer cells. They make blood cells, blood vessels, excuse me, in the tissues that they invade. We call that angiogenesis, and they are able to invade into other tissues and even travel far away, which is not normal. So we call these hallmarks cell-based hallmarks and tissue-based hallmarks. And this has been the idea of cancer, these cells that are constantly dividing, but we have a more complex view of cancer now. That's not just the cells, but it's the tissues, the blood vessels, and the immune cells that are trying to fight it, etc. So that's an overview of cancer. So we mentioned that a primary aspect of cancer is this cell division. So how do cells divide? They have a cell cycle. The cell cycle is has several phases. Mitosis, which we reviewed earlier, is the cell division, so that's the M phase. And after the M phase, you have the cell divide into two, and the cells can basically live normally, and we call that the G0 phase. If that cell is a dividing cell, in other words, are growing more, it will go into a protein synthesis G1 phase in preparation for DNA synthesis S phase, a secondary G2 protein synthesis, where they synthesize the machinery for the division, and eventually another mitosis or M phase. And you see this M phase has other elements to that. The prophase, where the chromosomes start to coalesce, the metaphase, where the chromosomes line up, the anaphase, where the chromosomes are starting to come across, and the telophase, when the chromosomes separate and the cells separate. So tumor treating fields are various frequencies of electromagnetic fields that have been shown in some animal models, not used yet in humans, but there's been some shown that some low frequency electromagnetic waves can treat some of these cancers as we described. Melanoma is one of them, with the optimal frequency being 120 kilohertz. Glioma with the optimal frequency being 170 or 250 kilohertz. So the tumor treating fields, we call them TTF, electromagnetic fields delivered in the region of the tumor, are of various frequencies. We don't know exactly the mechanism of this. One of the reasons I want to show you this chart of the hallmarks of cancer here is, does it work with evading apoptosis, self-sufficiency of growth vehicle signals, avoidance of anti-growth signals? Does it prevent angiogenesis, tissue invasion, metastases? We don't know all the mechanisms of this. So this is still a very open area, but the effects are definitely showing some inhibition of the growth of these cancer cells as a result of these tumor treating fields, with some frequency dependence. So another area of non-ionizing radiation application is in what's called transcutaneous electrical nerve stimulation, or TENS. TENS is a low frequency electrical current. Oh, I should say one thing, let me go back. One of the challenges of these tumor treating fields is that many cancers, of course, are deep inside the body. So you have a brain cancer, which is a glioma, you have a stomach cancer in the stomach, you have a liver cancer, and so forth. So delivering those tumor treating fields to those target cancer cells can be a challenge going through the body. Do you deliver it surgically? Do you deliver it through the body? extracorporeally is the term. So that's still an open issue. And the reason I mention this is transcutaneous. Cutaneous means skin. So transcutaneous means across the skin electrical nerve stimulation. This challenge of the body absorbing the electrical energy is minimized because our effect is through the skin. So it's a low frequency electrical current used to stimulate peripheral nerves, not the central nervous system, not the brain, but the peripheral nerves using skin surface electrodes to relieve pain. It's a non-invasive, non-pharmacological physical therapy modality. So we're going to talk about how that works. Modern TENS applications, so this is very commonly used. They have 4 specifications. The waveform, what does the waveform look like? Sinusoidal, sawtooth, etc. What is the frequency? What is the pulse width or duration? And what is the amplitude or intensity? So by varying these parameters, we get different effects. Now, we have a little better idea how this works than the tumor treating field, and there are 4 theories about the physiological effect of TENS. One is the gate control theory, which we're going to talk about shortly. The other one is the opiate mediated control theory, so that these electrical fields release some endogenous endorphins or opiates, endogenous opiates, endorphins to minimize the pain. Central basing theory, that there is some impact on the central nervous system. And local vasodilatation. Vasodilatation means opening up of the blood vessels in tissues that might be inflamed or ischemic and causing this pain. But the major theory is this gate control theory that we will talk about. So to understand that, we need to know a little bit about how pain works. So this is the skin, and the skin has many pain receptors here. There are essentially 3 types of pain receptors. There's the A delta fibers, the C fibers, and the A beta fibers. 3 types of peripheral pain fibers corresponding to 3 types of receptors, sensors in the skin. The A delta fibers are thinly myelinated, and they mediate sharp pain and the first pain. The C fibers are not myelinated. Remember, myelin speeds up the transmission, so these are thinly myelinated or unmyelinated. They mediate a slower, dull ache, the second pain. So you may have a sharp pain from a burn, and then that sharp pain goes away, which was delivered by the A delta fibers, and you get a duller pain, a slower pain, what we call the second pain, coming through the C fibers. And then you have the A beta fibers, which are mechanoreceptive. They're also pain receptors. They're thick myelinated very fast, but they're more related to pressure. And they also inhibit these projection neurons going up. So the gate control theory of pain is, if you have unmodulated pain, you have these C fibers delivering this dull ache, which is usually the pain that really bothers people over extent. It's chronic pain. Those C fibers, and those deliver this strong signal to the thalamus. You have stimulation of the secondary neuron, second order neuron going to the brain, and some inhibition of the inhibitory neuron. And that's the second pain C fibers that we described in the unmodulated case. If we can stimulate through transcranial electric nerve stimulation the A beta fibers, and those actually stimulate the inhibitory interneurons, so they inhibit, this is the gate that we call about gate control theory, then we have, instead of a strong signal sent to the thalamus is a region of the brain that is a relay for pain fibers. we send a weak signal to the thalamus, and that weak signal means less pain. Another way to think of this is many mothers know that if their baby or child is in pain and crying, one way to lower that pain is to distract them. So for example, if you have a pain here, you might rub on it, etc. So that distracting stimulus is a simplified form of this gate control theory of pain, where we use these electrodes to, in a sense, operationalize this concept that all mothers know with their crying infants. So we mentioned that the parameters are multiple different parameters, 4 basic parameters related to TENS. They are the frequency. So you have high frequency sensory TENS, we have low frequency motor TENS. We have the pulse duration, also varies with the high frequency sensory TENS. They are short pulses. With the motor TENS, they are longer pulses. The intensity is also going to vary with these. And the pain modulation system is different. The spinal gate theory, the supraspinal, the lower frequency might be related to the beta endorphin or endogenous opioid release. So this is the gate theory, the large A beta fibers we talked about. These would be directly on the A delta and C fibers in order to increase the endorphin release. So a rapid analgesia, because this is ultimately through enkephalins and endorphins, which are the endogenous opioids, this would be a slow analgesic response. The duration would be shorter in this case with the sensory TENS, and longer because it's predominantly more of a opioid release in the motor TENS. The sensory TENS will be acute postoperative pain, and the motor TENS will be more for long-term chronic pain. So our last topic for today is going to be about electroporation-based transfer of drugs, electrochemotherapy. We have a tumor, and we need to get a drug into the tumor. And you have, of course, the cell membrane around the tumor. So you inject the drug, but the drug does not get into the tumor. But if we can generate some electrical pulses that have a counter-ion effect, the alpha dispersion effect we described, that moves ions around the membrane, disrupting them slightly, that electroporation can essentially make the membrane more permeable, and the treating with that electrical pulse will allow the drug to get into the tumor. And that drug will then induce apoptosis, and the tumor cell will die. So we call that electrochemotherapy, using the electrodes not as a direct effect on the target. The target is still the function of the drug, but to facilitate that drug to enter the cell by influencing the membrane structure, as we described, because membranes have lots of ions, and those membrane structures and functions are especially susceptible to these electric pulses. So we've talked about non-ionizing radiation. And next week we're going to talk about ionizing radiation. That's a very important area where we will talk about medical imaging, X-rays, CT scans. We're going to be talking about radiosurgery and radiation biology. So these are very fundamental topics that are very commonly used in medicine. Ionizing radiation. Ionizing radiation has a very long understanding of the dangers of ionizing radiation. When we talk about Hiroshima, gamma rays, X-rays, X-ray exposure, radiation damage, and all that, we're typically talking about ionizing radiation. Of course, before we were talking about non-ionizing radiation, although they do also have biological effects. So in a sense, this is a little bit more, this ionizing radiation is a little bit more of a classical area in medicine, very well understood over 100 years, but it's very important, and we will talk about it at length. And there of course, future applications as well. So next week's question, which you do not have to do, is give an example of using ionizing radiation in medical diagnosis of therapy. You may want to think about it. For next week, and I'll send a notice about this, please start to search in the medical journals, in the scientific journals, based on your interest, for original research articles, and find one that you find is interesting and send that to me by next week. I'll say if it's a good article for you to do, if you need to look at something else, send me your selection. And again, I'll send you an email outlining this request so you can focus on that. So that's the end of today's lecture. I'm open for questions. You can ask questions directly or via the chat room.